Okay, so an interesting title to be given to come up with, and I think what is very important is I have no disclosures in this. Considering what I'm about to talk to you about, I think that's important. So when did all of this carry on start? Right? Well, Charlie Semba and Mike Dake sorted this out back in radiology in 1994, and they were really the first people to suggest the aggressive therapy for deep venous thrombosis. Their paper was using urokinase, and in the United States, we were using urokinase exclusively, really up until the end of 1999 or thereabouts. I know in Europe you had TPA much earlier than us, but it really wasn't until 2000 that we got into TPA. Around this same time, 94, companies started to pay attention to the fact that maybe clot removal might be a good thing, and two clot suction devices were developed at that time. The first was the Amplatz clot macerator, which was made by a company called Microvena at that time, and then the AngioJet, which was manufactured by a company called Possus. It's subsequently been purchased by Boston Scientific. Also, around that time, beginning in 98, so a few years further on, Scott Trerotola came up with this Trerotola device to kind of take clot out of dialysis fistulas. That was subsequently followed by a device from Bacchus called the Solera, followed by a device from Argon called the Cleaner. So there have been a number of these kind of macerating devices. What were we using before these devices? Well, this is the old-fashioned sheath approach or guide cath approach. So basically, stick the guide cath near the clot, put a syringe on the end of the guide cath, and suck as hard as you could. And that was really all we had available to us. The device on the left there is the Amplatzer Clotbuster, it was called. And this was powered by a compressed air tank in the room. And the little helix inside that metal tip would spin at 20,000 RPMs and create a vortex to suck clot out. The picture on your right, is the AngioJet device. I'm sure most of you are familiar with that. And that has gone from very small sizes, 4 French, 6 French, and now there's an 8 French Zalanta device, which is actually very good at taking out higher volumes of clot. And it uses a theory called the Bernoulli approach, which is where basically you pour high-speed water past a gap, and that creates a vacuum. The spinning wires and baskets, the picture on your left is the Cleaner device. The picture on your right is the Solera, which again, these high-speed spinning devices, these were really manufactured and are still labeled for use in AV dialysis grafts specifically, not even AV dialysis fistulas, AV dialysis grafts, because of the trauma that they can cause to the surrounding structures. As we all know, these have all been used elsewhere in the body. You have to be very careful. Don't get any of those baskets near a guide wire, or you're going to be in serious trouble. So what really happened then from about the late 90s or thereabouts, not much really came in the company landscape in terms of changing what we had in our armamentarium. However, in the last 10 to 15 years, there's been a major uptick in the interest of this kind of clot removal technology. And I think this is probably because at the time that this was happening, there were a number of clinical trials being published or in process. The first of these was the Cavent trial from Norway, which really showed that there is a statistical benefit for treating deep venous thrombosis. So again, companies start to look at this. And of course, that trial had a 5-year follow-up published in 2016, which again supported the use of clot removal. The other thing that happened in 2014, and companies pay a lot of attention to this, is the Cochrane Collaborative Review came out with its analysis of the thrombolysis or treatment of, essentially, acute deep venous thrombosis. And they looked at a bunch of studies, which is really what they do, and they do meta-analysis of all of this, and they specifically dealt with acute patients, with patients under 21 days of treatment, delivery of different drugs, streptokinase, urokinase, TPA, etc. Complete clot lysis and venous patency was obviously much better if you thrombolyze somebody than if you gave them anticoagulation. They showed in that paper, 2014, that post-thrombotic syndrome was highly significantly reduced if you used a lytic drug versus anticoagulation, as was leg ulceration, with a very significant number there. And they did, of course, show some increase in bleeding complications. So that type of stuff, along with what my colleague has just discussed, the ATTRACT trial, which was ongoing in 2014, 15, 16, and then 2017 was published, really showed industry that there's something going on here. There's a signal. You need to get on board with this. And as we know, a lot of different companies did, in fact, get on board with this. The other thing that was kind of happening in parallel to this was there was a rapid evolution in the treatment of stroke. And in the early 2000s, in fact in 2004, the Mercy retrieval device, which was a corkscrew device, was developed by a French scientist called Pierre Gobin, who came to UCLA and worked in the animal lab in UCLA and developed this corkscrew device while on sabbatical. And actually, he did very well out of this. And he launched a company called Concentric Medical. It turned out that the Mercy device, which works in the treatment of stroke, had a fairly high complication rate, and it weren't really comparative trials. It was just, this is a device that's there. This was rapidly followed then by the Penumbra device. Two gentlemen started a company which is based in San Leandro near San Francisco to develop a long sheath to suck out clot. That's essentially what they came up with. And they did actually achieve that result, and they were able to treat clot with the Penumbra device. However, at that time, if you go into the data, there's actually quite mixed complication rates, mixed data, etc. It was good, and it was as good as, if not better than, the Mercy, but there needed to be a lot of adaptations performed, which did happen over the next few years. So their technology is a soft tip, highly flexible, multiple transitions in the stiffness of the sheath, collapse resistant. So if you think about sucking hard on a straw, the straw will start to collapse. They had to prevent that. And those types of technological advances have allowed that company to flourish, and I'm sure you're all aware of them at this stage. So they start off at 4 French, now they're getting up to 6 French, now they're getting up to 9 French, then they're up to 12 French, and as you know, I'm about to show you where they're at today. So following the success of the Mercy corkscrew, the Penumbra vacuum cleaner in the early 2010s, stent retrievers then started to come on the market. So the first of these was the Solitaire, again for intracranial removal of clot, followed by the Trevo, very similar devices, and these did actually go into double-blind randomized controlled trials. There were some major hiccups on the way, as I'm sure any of you who do INR know, but in around 2015, they were able to clearly show clinical benefit to patients if you got them in and did this type of stent retrieval clot removal early, and that's now the standard of care in treating acute thrombotic stroke. So what about the world of DVT? Well, the utility of these new systems was not lost on the companies that were pumping money into this development, and they began thinking, well, how can we use the same technology to take clot out of the coronaries, deep venous thrombosis, or deep pulmonary emboli? And in fact, in some ways, these territories are easier, bigger, and they have less severe complications compared to stroke, etc. So that has led to really an explosion in what's available for clot removal and development of new companies that we all see on the floor today. Results have been mixed, and the technology continues to adapt to new requirements. I mentioned Penumbra before. This is just to get you up to speed now. So Penumbra is, in the medical terminology, is an area surrounding an ischemic event such as an embolic stroke. That's where the name comes from. Again, they were initially developed for the head, but they're now much bigger, stiffened, longer, etc. So we started using them, I remember, back when we were doing SFA, PTA, and we would use the Penumbra device to go down to suck out any clot that had dislodged from your SFA, PTA before the development of those little baskets to catch the clot. So that's where we started using it. So 6 French or 4 French. But now they've rapidly grown this up to 7, 12, I think it's called the 12 Lightning, and they've just released the 16 Flash, which is a very big device. It's on the floor here if you want to go look at it, and that's primarily for use in DVT and pulmonary embolism, not stroke like they started off doing. And this is a map of where Penumbra goes in the human body, and you can see they've got a tube for pretty much everywhere that you have a tube. And this is the Lightning Flash 16 French device, which is actually a stainless steel cut product, so it's very flexible, but retains its diameter. Again, you can put very high levels of suction and it won't collapse down, and clearly you can get out a significant amount of clot. Other clot removal devices were also coming on the market around this time. The one on your left is the AngioVac suction system. This is made by AngioDynamics, and this is primarily for use in the right atrial area of the body. It's a very good device if you have one of these nasty little clots, kind of stalagmite, stalactite type clots on the end of a dialysis catheter or just clinging on in the right atrium. It's a little too stiff, in my personal opinion, to be going around the right heart, pulmonary arteries, and there have been some issues with its use to try and suck out DVT. But the concept is very interesting in that the funnel flares open and therefore is obviously able to capture more debris. The device on your right is the Jet-Eye. This is sort of available in 6 and 8 French. Don't be too surprised if you see this come out in 12 or 14 at some time in the future for DVT, but it can be quite effective. Okay, what about those stent retrieval systems? Well, again, we talked about the Solitaire and the Trevo. So now Inari comes along and says, okay, anything you can do in the head, we can do elsewhere in the body. And so they've developed 2 different devices. 2019 was the FlowTriever, 2020 the ClotTriever. FlowTriever primarily for pulmonary embolism. This is the FlowTriever version 1 on the bottom and version 2 on the top, really. And again, the idea is you advance this into the pulmonary artery, open it up, pull the clot back. And the same with the second one here. You can use it in combination with a drug if you want to put TPA or something through the catheter, and has been very effective and is widely used today, and certainly it probably is the primary device on the market with the Flash 16 now from Penumbra for the rapid aspiration of pulmonary emboli. The ClotTriever is a little smaller. There are 13 and 16 French systems, but the device itself is 11 French. Either 13 or 16 French sheath, but the device is 11 French regardless of what sheath you use. Why use a bigger sheath? Well, it gets more, if you have more clot in the stent as it's coming back, there's more room for that stent to come out. It's an 80 centimeter working length. When the stent system itself is open to capture clot, it's 16 millimeters in maximum diameter, and it can contain up to 31 centimeters in length of clot, allowing for removal of considerable amounts of thrombus. Don't use this really in the inferior vena cava. It's an iliac and femoral device. The trouble with using it higher up, sort of to the level of the renals or whatever, is that now the basket's being opened up much higher than that. Now you're up into the right atrium, and in fact, it's probably not long enough to do that in a tall patient anyway. So it's really an iliac-femoral device. I think probably the big picture is probably the best one. You push the device up, open up that basket, really a dress, I suppose, and you pull it back and get the clot into the basket and take it out through the sheath. I have had personal, very good experience with this, and I can see my colleague in the back of the room who uses it all the time. And we're very happy with this device. And again, this is the kind of patient for which this is really effective. Large volume of clot in the inferior vena cava, I beg your pardon, in the iliac vein rather than the IVC. Okay, to finish up, stents. So since 2011, there are new specifically designed stents for iliofemoral use. The first was the Cook-Zilver, Vena, then the Optimed, Veneti, etc. Medtronic and Optimed have another one too. So which stent and why? Variations in flexibility, stiffness, size, open versus closed cell design, introducer sheath size, diameters of the stents, etc. You need to know all of this if you're going to get involved in the iliac or stent game. And as you can see, they all look fairly similar. They have different stiffness and characteristics, but they basically do the same thing. And here's just again a stent being opened in a left May-Thurner type anatomy with an excellent result afterwards. These stents are bigger, stronger, I wouldn't say easier to use, well, easier to use than the stents we used to have, like the wall stent, etc. And last slide, basically, what else is on the market that wasn't on the market years ago? Well, there are new IVUS catheters on the market today. The one that you see on the left there is the new Volcano device, which Volcano was purchased by Philips. This is very helpful for those of us who do frequent iliac vein stenting. I think it's a controversial thing to say, but I think it's probably standard of care that you really should be doing IVUS if you're going to be doing a significant volume of iliac vein stenting, just to make sure you can put your stent in the right place and size it correctly. And then the device on the right, as many of you know, the drug delivery system, the ECO system that uses ultrasound to accelerate the use of TPA. Somewhat controversial. Some people firmly believe in this device, and I've used it a lot in the combination with TPA, and then other people would say don't use much TPA, or it doesn't matter if you use the ultrasound device. Thank you very much.